gastroenterologists see in clinical practice, irritable bowel syndrome. Irritable bowel syndrome, whether you are a hepatologist, a therapeutic endoscopist, or whatever pancreatologist, whatever batch of gastroenterology you are on, you are bound to see patients with irritable bowel syndrome, and they constitute the so-called bread and butter of gastrointestinal practice. Not only that, this used to be a very subjective specialty a few years back. But in the last few years, there's been a huge amount of research in terms of neuroendocrine system, the hormones that are coming up, the gut microbiome role, and a lot of objective evidence is coming, and the management is becoming more rational. So I think with all this in the view, because of these new changes that are coming up and the focus that Rome Foundation has put on this, I think this is a very good time that Mohan has decided to have this topic as a principal one on a Sunday evening. We have two very eminent speakers this evening. I'll introduce our first speaker who will be talking first, the first part. He's Dr. Amrendra Singh Puri. Amrendra is now the Vice Chairman of the Institute of Digestive and Hepatobiliary Sciences, Medanta, in Delhi. He did his MD from Christian Middle College, Ludhiana, and subsequently did his DM from SGPGI. He's been a professor of gastroenterology at the GB Pant Hospital for several years, and since his retirement has taken up this position at the Medanta Hospital. Amrendra, of course, I know personally very well. Not only is an outstanding teacher, in fact, many of his students swear by him. We have some of them who have joined us after the DM, and he's a real god to them. He's an iconic figure in gastroenterology in India, and his work in especially inflammatory bowel disease, irritable bowel syndromes, and so on have become very important. And therefore, it's a great pleasure to introduce Dr. A.S. Puri this evening. Amrendra, we are eager to listen to what you're going to tell us. You probably have to unmute your mic, yeah.
Okay. Can you hear me,
we
sir?
can hear you now.
Okay. Thank you for that very kind introduction. I'm not sure I deserve all of that, but anyhow, I'm going to start sharing my.
So Amrendra is going to talk to us predominantly on the situation of IBS in India, because there are certain peculiar features that we face and how we should approach and treat these patients. As the slides are coming up, we'll just wait for a second. And
so are my slides there?
No, still not yet.
Still not there. Okay. Is there some problem there? Shivi, I think we just need a little bit of help.
You see the entire screen, you can click on the entire screen.
Yeah, now it's coming.
Yeah, just come. Yes.
Yeah.
Okay. So thank you very much for the kind introduction, Dr. Nagi. And today I've been entrusted with the not only the job of the opening batsman in lieu of Professor Gui, but also I have been entrusted to talk to this august audience on challenges of management of IBS in India, which I think is very important. Now, my opening slide you can see is I'm going to start with something very basic. That what is the normal stool frequency and a comparison between East and West. So here I've taken 3 countries, and you can see that in India, the mean or the median bowel motions are 2 per day, same as in Iran. In China, it's 1 per day. But when you look at Europe and US, the figure is 3 times per day to 3 times per week. The problem is that all the literature that we have is based on this information. So diarrhea, therefore, is classified as anything more than 3 times per day. And conversely, constipation is if you have less than 3 bowel motions.
Sir, hello. Sir, sorry to interrupt you. Sir, can we just stop for a couple of minutes?
Yes, sir. Sure. You're asking me? Hello?
Yes, sir. Yes. Wait for a couple of minutes, sir.
Some technicalities, Amrinder. We'll wait on.
Okay. Dr. Nagi, you'll have to tell me when to start.
Yeah, no,
Uh,
we'll tell you.
Sir, this
So
on the
this is
chat
a
box.
technical problem. We are
Yeah,
having
yeah.
some difficulty in getting this out into the audience. So just a second. I think as soon as they solve this, we can.
Hello. This is the first time we have had a technical problem here
Yeah.
on this because both the previous webinars went so beautifully flawless, perfect it went. So there is some live streaming problem here which has come up now. This StreamYard platform is from the United States, and it was working very well in the previous webinars. Even before that, I have addressed one on this. We never had a.
No, but where is the host team? Is it in Coimbatore or it's from somewhere other
Mumbai.
city? Mumbai. Okay.
The host will tell us when it's ready, because we're still.
Yeah.
Yes.
Looks like
We'll tell.
we have
Wait
to
for 2 minutes.
redo right from the beginning, Nagi. Right from your introduction, we have to go. Very sorry for this.
No news from Singapore. No news from Singapore, no?
Not yet. That
Somebody's
is what.
contacting him. Somebody's ringing up to talk when B.
No, because he never gave his telephone number, so that became a problem to me.
Sir, now we can start, sir. We are live
I
now.
think, Uday Koshal will have his cell number.
Uday is not picking up the phone. So if from AIG, if somebody can contact Uday, then we can probably go. Monique, you can start.
Yes, sir. We are live now. We can start our session, sir. Over to you, sir.
No, ask him whether we restart or we continue.
Monique,
Sir, it's better you restart, sir.
Okay.
Okay, then you can start. Okay, you can start. You can read out. Go, quick.
I think we'll make it short. Just no need of full introductions.
Okay,
We'll make it a little shorter. I think.
A very good evening to you all. Welcome to this GI masterclass. On this special Sunday, we have eminent star faculty eagerly waiting for you to enlighten you on current trends in managing IBS. Now, may I hand over to Dr. V.G. Mohan Prasad, Chairman, BGM Hospital, to introduce the speakers and moderator.
So I have a great pleasure in welcoming all of you to this third webinar among the 4 webinars that we have organized along with the VGM Foundation and Asian Institute of Gastroenterology. Today is a wonderful day because we're going to discuss about managing IBS in 2020. So what is new about it? So I have a great pleasure in thanking Professor B. Nageshwar Reddy for joining hands, taking AIG along with VGM for doing this work, and also thank Abbott for providing this platform. So we have Professor Ko Can Wee from Singapore who's already joined us, Professor A.S. Puri, Professor Manu Tandon all with us. But let me introduce the moderator of this program, Professor D. Nageshwar Reddy, and then I'm going to hand over to him. So he will introduce the speakers, Professor Gui first, and then after his lecture, he'll introduce Professor Puri and then request Professor Puri to speak, and then there'll be a panel discussion with all the three eminent speakers, and then we will with Professor Manu Tandon also on the panel, so that people can post their questions on the chat box. These will be picked up by the moderator and presented to the speakers. So I have a great pleasure in introducing Padma Bhushan Professor D. Dr. Nageshwar Reddy. He's MD/DM DSc, and with multiple qualifications, and more than anything, he's the chairman of the Asian Institute of Gastroenterology at Hyderabad in India, and he's a past president of the Society of Gastrointestinal Endoscopy of India, and more than anything, the pride of India as the past president of the World Endoscopy Organization. So his expertise in therapeutic endoscopy is unparalleled, and also in notes, transgastric, approaches and endoscopic surgeries. He has over 560 papers in national and international peer-reviewed journals, and he has contributed to 10 chapters in 10 international textbooks of gastroenterology, edited 3 GI endoscopy books. He's on the editorial board of so many journals, right from GIE, Digestive Endoscopy, WGO, World Gastroenterology News, and whatnot. He's a peer reviewer of so many journals, including Lancet and GIE and Endoscopy. He's an awardee recipient of Viceroy Award and Padma Shri and Padma Bhushan Award from Government of India, Master Endoscopic Award from ASG International Leadership Award, and Australia Master of World Gastroenterology Organization Award. He is an honorary fellow for so many country societies. He has given so many orations. And, let me hand over with this introduction to Professor Padma Bhushan, Dr. Nageshwar Reddy, for moderating the whole session and taking forward. Thank you, Nagi, for being with us.
Thank you, Mohan. I'd like to thank Dr. Mohan Prasad and the VGM Foundation for giving us this opportunity to participate in this very important series of symposia. Today's symposia, especially on irritable bowel syndrome, is extremely important because irrespective of whatever field of gastroenterology you're practicing in, hepatology or therapeutic endoscopy or pancreatology, you're bound to see these patients in large numbers, and it's better to understand this disease well. In fact, even for the general physician, practicing physician, this becomes extremely important. Over the last few years, there's been a change in how we understand irritable bowel syndrome. The subjective elements have been replaced by more objective evidence, and of course, we are better treating these patients. To discuss this subject, we have two very eminent gastroenterologists, one international, one Indian, as is the forum in these seminars. So we'll start first with Professor Koch and Wee, who is very well known in this field of functional bowel disease. Professor Gui is the Adjunct Associate Professor of Medicine at the National Institute of Singapore. His work is mainly on post-infectious irritable bowel syndrome. He has also done a lot of research on epidemiology and Asian sociocultural perspectives of GI diseases, which is very important for us. He's worked on role of inflammation, gut microbes, probiotics, sleep disturbances, and so on in functional gut disease. He is a founding member and the past president of the Asian Neurogastroenterology Motility Association. He has chaired the Rome Asian Working Team as a member of the Rome 4 committees and a recipient of Rome Foundation Research Award and a lead author on the Asian Consensus in IBS, which has been published some time back and is extremely popular. I personally known Professor Gee when we worked with him on a project on irritable bowel syndrome, and he's not only a fantastic worker, but a great human being. Professor Gui, welcome to this seminar. There's a large number of Indian gastroenterologists and physicians very eager to listen to you. Thank you very much for being here this evening.
Thank you. Yeah, I'll share my slides first.
Yeah.
You're seeing entire screen, sir. It says entire screen. You just click on it. So just
click on entire screen.
Sir, just click on the share screen option. Sir, have you clicked on share screen option?
Professor Gui, can you click on the share screen option on your laptop? Share screen option.
I think it's a hang and it's not live at the moment.
I know it's coming now. Maybe something in there.
Yeah, it's come on. Yes.
Okay,
yes.
I'm sorry. I'm sorry. There was a bit of a hiccup there.
Yeah.
So
So if you can click on share screen, then probably we'll get your screen slide. Yeah. Now
Yes.
we get. Yeah.
Click on the entire screen, sir.
Yeah.
The center of the screen. Right.
Yes, sir. We are live. We can see your screen now. Just open your presentation, sir.
Yeah. Open the PowerPoint presentation on your Google Chrome.
It's open.
Open the PowerPoint.
Open. It's
Then
open.
you click on the screens at the center of the screen.
Okay, I've clicked on the center of the screen.
And then click on the PowerPoint on your screen, sir.
Sir, just now stop sharing and I will guide you from the beginning, sir. Just stop sharing.
Okay. All right.
Yeah, now click on the share screen option. Yeah, now from the entire screen, just click on that screen and then click on the share button again. Yeah, sir, now open your presentation. Now open your presentation. Just escape from this, sir. Just escape from this. Yeah, now open your presentation as usual, sir. Yeah, just minimize. Yes,
Yeah.
yes, your screen is visible, sir.
Okay.
Yeah, just go for full screen.
Okay.
Yeah. Now we can.
Yeah, sir, perfect.
Okay. A very good evening to everyone in
Can I
India.
interrupt you, Professor Gui? You can also
Sorry?
click on this that hide in the final one small statement is a StreamYard is streaming. So that last icon there, hide. So that will go away from, no, not there, not there. No, sir, no, sir. Down there onto the bottom of your screen, the white with the blue.
Still bottom, blue and white. Yeah.
Yeah, hide. Just press on the hide part of it. Yeah, that will go away. And now you can go to a full screen mode, sir. Oh no.
Sorry, where's the full screen mode?
Sir, I think from upper side there is one second option is there.
On top, sir.
On top, sir.
On top. Yeah.
Yeah. Yes, now select either of them.
Sorry, select where?
Just
No.
just any of these, sir.
First one, sir. First select the drop of the first one, sir. Yeah. Yes.
Yeah.
Yeah.
Okay,
Yes,
good. Okay, good. Okay. Yeah. Okay, so my apologies for this little bit of hiccup. Okay, so I've been given uh, the privilege to speak to this big Indian audience, and I'd like to thank Dr. Mohan Prasad for this kind privilege, and also the very appreciative introduction by Dr. Nageshwara Reddy. So my topic today is to talk about diagnosing irritable bowel syndrome, management, and the preventing of recurrence of irritable bowel syndrome. So before I start, I would like to just introduce what irritable bowel syndrome is. It's part of a group of conditions known as functional GI disorders, which traditionally we have defined as the absence of organic pathology. However, because of the inability to find some organic pathology, we have often in the past ascribed the condition to a brain gut disorder. And sometimes we have taken it to mean that it's all in the mind. But I hope that in the next few presentations, I will convince you there's much more than the absence of organic pathology. So for the diagnosis of irritable bowel syndrome, we have all been trained to recognize that the Rome Foundation has come up with a set of criteria for irritable bowel syndrome. And the latest iteration of the Rome criteria is the Rome 4 criteria. And as I've shown here, there's a lot of emphasis on pain. And then there's a great deal of attention to details as to say that the symptoms should occur at least 1 day per week in the last 3 months. But I think more important than that is we have to appreciate that the abdominal symptom, particularly pain, should be related to defecation associated with a change in frequency of stool and a change in the stool form. Some of the little details of this Rome criteria is that these symptoms should have existed for the last 3 months, with the onset about 6 months before the diagnosis. So those of you who have been following the progression of the Rome criteria will appreciate that Rome 4 is the latest and Rome 3 obviously was the preceding one. So let's look at what are the differences between Rome 3 and Rome 4. The biggest change with Rome 4 is taking away discomfort as a symptom of irritable bowel syndrome. And the rationale for this was that the term discomfort was considered to be a non-specific term and has different meanings in different languages and is ambiguous to patients. The other big change was to move from 3 days a month to 1 day a week. Minor changes was that instead of insisting that the symptom would improve with defecation, is the recognition that it is possible for IBS symptoms to actually increase after bowel movement, and then minor little terminology changes will be removing that it must be associated with onset of changes in stool frequency and stool form. But I would raise the question, should all roads lead to Rome? Now, keep in mind that the Rome 4 criteria was developed based predominantly on a study of a US population. And this is in the community. It has nothing to do with patients that we all see in real life. So to be fair, the Rome 4 criteria should really be applied only for clinical research and treatment trials, and not necessarily for real-world patient management. One of the big deficiency of the Rome 4 criteria is that it has totally left out bloating, which I'm sure most of us practicing in Asia appreciate. It's such a big component of our IBS symptoms. And then the other big weakness of the Rome criteria is that it was all focused on the US population, who in my opinion may have limited the vocabulary. And the Asians may have a different symptom emphasis. So what has happened between Rome 3 to Rome 4, as exemplified by this study from China, is such as shown in the screen. So in this study of 130,300 over tertiary care GI patients from China, 12% of the patients met Rome 3 criteria, whereas when the Rome 4 criteria was strictly enforced, the diagnosis of IBS fell by half. And if we look carefully at what's the difference between Rome 3 and Rome 4, as shown in the table below, the Rome 4 IBS patients all had more severe symptoms. Total IBS severity was higher in Rome 3 than Rome 4. The severity of abdominal pain was again higher in Rome 4 than in Rome 3. The only difference really was that with abdominal distension, there was not much difference between Rome 4 and Rome 3, but the quality of life of IBS defined by Rome 4 was certainly worse with Rome 4 than Rome 3. I think we need to step back a little bit and think how relevant is this Western paradigm to our Asian populations. And here I pay due respect to one of our godfathers of gastroenterology not only in India but in Asia as well. So the thing is that I think we all recognize that in Asia we have many patients and we have little time to go through all these agonizing Rome criteria details. And if we are really honest with ourselves, we would acknowledge that for us as gastroenterologists rather than psychologists or psychosomatic physicians, endoscopy is a lot more appealing than psychology. So the Asian Society, the Asian Neurogastroenterology and Motility Association came up with what we felt was a more pragmatic and practical approach for our Asian physicians. So we would look at the three key symptoms, and we are more liberal. We will say any abdominal pain, bloating, or any abdominal discomfort. And so long as any of these symptoms are associated with one of these bowel defined criteria, then we will start to consider that this is a possible irritable bowel syndrome. And then using a more kind of practical time frame of 3 months or longer. However, we recognize that this clinical criteria may have some limitations because of the lack of investigations. So we have applied alarm features as a practical approach. And then we recognize that these patients may not be established as irritable bowel syndrome. So we should still keep an open mind and consider that they are just probable IBS, but we should keep a very close follow-up on these patients so that in case they do not respond to standard treatment for irritable bowel syndrome, then we may need to investigate these patients for potential organic pathology. So how do these different criteria perform in our society? So this is a study by Uday Ghoshal examining all the criteria that were enforced in 2013. So Manning criteria, as I think all of us were brought up about irritable bowel syndrome, is the mother of all IBS criteria. It is how we started conceptualizing what are the symptoms that are attributable to the bowel as opposed to the stomach. The limitation of Manning criteria is that it doesn't set a time frame. So because of this, then some of the patients with more acute type of symptoms may still be classified as an irritable bowel syndrome. In any case, in this Indian cohort, these are all established IBS patients diagnosed by very experienced gastroenterologists across the length and breadth of India. So we compare between Manning criteria and Rome 1 criteria. Rome 1 criteria has a positive pickup rate of about 68%. Rome 2 criteria drops to 40% because of its requirement of the patients having at least 12 months of symptoms. Then in the Rome 3 criteria, we are increasing the yield for positive pickup of irritable bowel syndrome. But both Professor Ghoshal and myself feel that the Asian criteria actually hits the sweet spot so that we get a balance between more confidence with this being a functional disorder versus the possibility of overdiagnosing irritable bowel syndrome in a patient with organic pathology. And actually, the European Society reinforces a lot of what we have felt. So for the European Society, they, like ourselves, take a more pragmatic approach. We don't insist that it must fulfill certain kind of bowel criteria, and also at the same time, they only require a time frame of 3 months, and they take a more clinical pragmatic approach where you base it on symptoms, base it on minimal investigations, and then you take a positive approach to diagnosis. The European guidelines are actually very practical. They also recognize that bloating, distension, and flatulence are kind of common symptoms among IBS patients. And even beyond that, they recognize extra-intestinal manifestations or symptoms. And actually, this is such an important feature of functional disorders and irritable bowel syndrome that we should actually consider that those patients who present with more than GI symptoms are really very likely to be irritable bowel syndrome. And then they provide useful guidelines on what are potential alarm symptoms for organic pathology. So age is there, blood in the stools, weight loss, and then very clinical assessment, ascites, and then also simple basic clinical investigations. The investigations recommended by the European Society are also, in my opinion, very doable and practical. So all patients should have at least this minimum investigations. And the idea is that we're looking to exclude inflammatory bowel or other inflammatory conditions. I want to highlight here that for IBS, patients with diarrhea, you should pay particular attention to exclude organic pathology. So in areas of high celiac disease prevalence, and I have observed that in India, actually you do have a fairly high incidence of gluten sensitivity. So you should consider serological uh, testing for gluten pathology. And then, of course, if you're looking at a tropical area, it's also important to do stool tests to exclude parasitic infections, but also tropical sprue, which is still quite prevalent in our part of the world. And then here they uh, they encourage that if the patient is not responsive to standard treatment for irritable bowel, we should consider breath testing to exclude carbohydrate malabsorption. But I think now we also want to recognize the potential role of small intestinal bacterial overgrowth. And last but not least is we need to be very cognizant of the risk for colon cancer. So these are the suggested alert features. And so in this kind of context, we should go straight to colonoscopy. Next, I want to touch on managing IBS. To me, it is most important that for managing IBS, we recognize very early an IBS patient and take them in hand and really managing them actively rather than leave them to wander in the wild and then getting all sorts of untested treatment proposals from naturopaths and other people. So recognizing IBS by having these kind of symptoms in our mind that the moment the patient comes into us, we must start thinking of IBS immediately. And it is, I think, really helpful for the patient to have a good explanation of how they develop irritable bowel syndrome, what has gone wrong in their gut with IBS. And then we should also address patients' expectations and accordingly match their treatment requirements. I want to share with you now some of the discrepancies between patients and physicians. This is a study from Canada where they interviewed patients and physicians and looked at what the patient would consider as a plausible explanation for their symptoms, what kind of investigations that patients expect, and what is their preferred management approach versus what the physicians dictate to their patients. So for the patients, many of them, the majority would in their mind think that this is a food intolerance issue, but in the physician's view, a lot of them have been indoctrinated to think that IBS is simply due to a lack of fiber or to psychological factors. Then for investigations, the majority of IBS patients, regardless of their age, would expect some investigations give them confidence that they don't have an organic pathology, especially colon cancer. Whereas in the physicians, they restrict investigations to only the elderly subjects. With regards to management, the IBS patients, number one, a priority is to get good, firm, confident reassurance from their physicians. And yet, for the physicians, the number one prescribed treatment is dietary therapy. The next preferred treatment by IBS patients are with medications. But for physicians, they're going to send them off to the psychologist and maybe the dietitians, and then only as a third line approach to prescribe drugs. For the patients, actually dietary advice comes right at the bottom as opposed to the physician's prescribed treatment. This is a study from the US where it shows such an unfulfilled expectations for IBS patients, at least in the US. The IBS patients expect comprehensive information from their physicians, and in this survey, IBS patients were very disappointed. Only one third of them had this expectation fulfilled. IBS patients in the US expect good information about IBS studies and medications, and yet their physicians only were able to provide this in about, again, one third of the physicians. And then the IBS patients are expecting good support, strong support from their physicians, and they perceive that this was only supported by their physicians in about half of them. Last but not least, IBS patients hope that their physicians can give them a chance of recovering from their IBS symptoms, but their physicians were a lot more pessimistic. I think before we even go into making a diagnosis of IBS, we have to try to think of why our IBS patients are so unhappy with a diagnosis of IBS. This is a study from Canada where they looked at the match between doctors and patients, both by gastroenterologists and general practitioners, and it shows a concordance in just over half of them. For gastroenterologists and close to only one third for GPs. But if you look at the details, in fact, actually the majority of IBS patients and gastroenterologists agree that they don't have a firm diagnosis. And patients and gastroenterologists only agree on the IBS diagnosis in 1 out of 27. The similar kind of pattern that we observe between GP and patients. So patients are really very reluctant to accept a diagnosis of IBS, and physicians are also uncomfortable to make a diagnosis of IBS. So in my opinion, I think a lot of the resistance to accepting a diagnosis of IBS, particularly by patients, is because of this narrative that has been going on for such a long time that IBS is all in the mind. And nice, very detailed, thought-provoking concept maps like this one by physicians from the West reinforce this idea that IBS is a psychological problem and it's all in the mind. I will share with you that my patients hate this diagnosis of attributing the IBS to a psychological problem. And I think in many of them, they are right. Because this study from Australia shows clearly that there's actually a bi-directional relationship of functional GI and IBS and psychological distress. So in this study, they followed up people in the community over 12 years. In one arm, they looked at people without a functional GI disorder at baseline and divided them into those with anxiety and those without anxiety And indeed, after 12 years, those with anxiety were more likely to develop IBS than those without anxiety. But interestingly, there was also the other direction. So here they looked at patients without anxiety at baseline, but had actually IBS at baseline and no IBS at baseline, and then followed them up for 12 years. And after 12 years, those with IBS were more likely to develop anxiety than those without IBS. So I think we should be fair to our patients and acknowledge that IBS is not always a psychological problem. So now we have a new narrative on IBS, and this is called a gut-brain disorder. So this recognizes that there is an interplay between luminal factors, including food, microbiota, and bile acids, with the mucosal uh, disturbances. So what this is saying is that the internal microenvironment of the gut actually plays an important role in inducing changes in the enteric nerves and immune activation that then set up the manifestations of IBS, including the psychological manifestations. Just to convince you that, in fact, the idea of IBS being a microorganic or microenvironmental disorder actually started with the recognition that infection is actually a very common cause of IBS. And this world map published in 2019 shows you the worldwide prevalence of post-infectious IBS. So that this gives you the percentage of patients who have infection who subsequently develop IBS is really quite high. And the research in post-infection IBS helps us to understand how you can have an interaction between organic factors and psychological factors. So here it's showing that when the patient is exposed to an acute infection, there is dysbiosis, there's bile acid malabsorption, there's increased intestinal permeability together with the acute inflammation, which all act in concert to sensitize the sensory nerves. And then in some of these patients who are predisposed genetically and because of the severity of the infection and as well psychological factors, they can't seem to get out of this situation so that they then develop chronic low-grade inflammation that continues to drive the pathophysiology of IBS and the manifestations of IBS symptoms. Next, I want to touch on how we can better stratify our treatment for IBS. And this comes from the guru of IBS or Rome, but he says you should look at patients in different severity grades. So the mild patients are here, the moderately severe patients are here, and the severe patients are here. For the mild patients, we recognize that the majority of them, the primary problem is a bowel dysfunction. And the psychological aspect is actually a minor little problem. For the severe patients, it's the other way around, that actually the psychological aspects are predominant and the gut problems are minor. Now, this is the kind of numbers that you see with tertiary centers, particularly where the psychopathologists come in and they are selecting all the more severe, hardcore, severe IBS patients so that they actually see a high percentage of psychologically disturbed IBS patients. But I will put it to you that in our kind of practice where we see all comers coming to us, majority of our patients will be in the mild and moderate situation, and it's only a small minority, maybe 5% that have a severe symptoms. So this is the roadmap for how we can approach patients according to their severity. So according to the severity grade, so those with mild symptoms, and in fact, for that matter, all the patients, we should start off with dietary and lifestyle management. And then for those who continue to have symptoms after this, we introduce gut medications And it's really only in the hardcore, severe, psychologically disturbed patients, then we would start thinking about psychologically directed treatments. So I think we should, as physicians, as see a broad spectrum of physicians, really focus on the mild to moderate patients. And in my practice is whenever I see a severe IBS patient who is psychologically disturbed, I don't waste time treating them. I send them off to the psychiatrist. So with regards to diet, I think the biggest help to changing our mindset of IBS is this concept of the FODMAP. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So these are the kind of FODMAP sugars and where the sources are. You will see that the majority of these food sources are actually fruits and vegetables. And in Asian populations, it's especially important that the dairy products, particularly lactose, is also an important triggering factor. So the evidence to support the efficacy of a low FODMAP diet comes from Australian studies where they looked at IBS and healthy controls and look at the kind of symptom response with a typical Australian diet versus a low FODMAP diet. So you can see that bloating is almost half with the low FODMAP diet, abdominal pain also half with a low FODMAP diet, and that the patients appreciate an improvement in the stool consistency. Next, we go to drug therapy for the patients who are still not responding to diet and lifestyle manipulations. So here we get some guidance from the Rome committee. They recommend a treatment based on predominant symptoms. And here I show you the Rome 4 recommendations for diarrhea and constipation. So this is the list of treatments for diarrhea that have some clinical evidence base, and these are the treatments for constipation. For abdominal pain, these are the recognized treatments that can be useful for IBS patients with abdominal pain. So the smooth muscle antispasmodics, I think we have otilonium, we have mebaverin, and peppermint oil is also a very attractive proposition. It has is well received by patients. It's only when we move into the antidepressants, then we meet with some resistance because patients, as I shared with my own experience, hate to be classified as having a psychological problem. So we should approach IBS as a pyramid. The majority of IBS patients, you can target their symptoms by addressing the motility disturbance or the sensory disturbance. And it's only really those who fail the first line treatment, then we will move up to the centrally directed treatments. So with centrally directed treatments, for most of us, psychotherapy will be the ultimate endpoint. So it's a question of should we refer our IBS patients to a psychiatrist or psychologist? And then what benefit can they bring to our IBS patients? And if we're really honest with ourselves, if we look at the evidence base for psychotherapy in IBS and ask ourselves, does it really work? So this is a meta-analysis by Ford. So a critical evaluation shows that this kind of meta-analysis actually encompasses a multitude of different psychotherapy, cognitive behavioral therapy, hypnosis, and various relaxation methods. And there's like 36 different RCTs encompassing 2,000 over patients spread over all these various treatments. So the pro psychotherapy people will tell you that overall IBS symptoms improve in 48% on active psychotherapy versus 24% on non-psychotherapy or control therapy, which sounds very good because like you're doubling the response rate. But keep in mind that if you look at it the other way around, overall IBS symptoms actually did not improve in 52% of patients subjected to psychotherapy. So it is still the minority that actually improves the psychotherapy. Furthermore, if we are very critical with the quality of the evidence on psychotherapy, there's actually no study of psychotherapy that's at low risk of bias. The majority, 83% of psychotherapy studies were actually unblinded, and a lot of them, majority, there was no concealment of allocation, and 9 studies were from the same center. And then if you look at where the studies come from, the majority were from the West, and the majority of patients recruited in these studies were white female subjects. So if we truly support evidence-based, we will say that it only works for white females and there's no proof for our Asian subjects. On the other hand, I show you here just 2 examples where peripherally directed agents actually are able to produce long-lasting improvement in IBS. This is one study with rifaximin, which shows you that after 14 days of treatment, the actively treated patients continue to do better than the placebo. This is a study with an antispasmodic, which shows that after a long period of treatment, those treated with the antispasmodic continue to do better than placebo. So I want you now to think a bit about what should be the role for us as gastroenterologists. Should we play a small role and then send out our patients to community alternative therapists, the dietitian, the psychiatrist? Should we take a back seat and actually just step out of the equation altogether? Or should we take the dominant role and be the director and tell our patients where they should go and who they should engage with? So, in conclusion, I want to just share personally my experience. I think that I get the most positive response when I think of IBS early in the diagnosis, rather than think of it as a diagnosis of exclusion, last resort. Rather than explain IBS as a psychosomatic disorder, I find that patients are more comfortable with what I call a biophysiological explanatory model. So we bring in both the inflammatory situation, but as well as the immune system and the microbiota, and as well the psychological component. I think the most important thing is not to be pessimistic about IBS and tell the patient it's an incurable condition, there's no effective treatment. We should be more confident because if we actually look carefully, there are data to say that patients can overcome their IBS if we are more positive and we take a broader perspective. So in conclusion, I hope that the audience will now appreciate what a challenge IBS is. It's a large creature, it's a multifactorial problem, and that we should all see it as the ultimate goal for a holistic physician. Thank you very much, ladies and gentlemen.
Thank you, Dr. Dweep, for that excellent talk. In fact, you've drawn the clear borders for diagnosis and treatment of IBS. You have touched on certain new pathophysiological aspects. You have given us the Asian view, which is very important. And finally, you have given a very practical aspects of how these cases should be managed. I know it's very late in Singapore, and we hope you could join us later for a Q&A session, which is going to come shortly after Professor Amrinder Singh's talk. So we now have Professor A.S. Puri to talk to us. Amrinder, of course, is very well known to the Indian audience. So a brief introduction. He is currently the Vice Chairman of Institute of Digestive and Hepatobiliary Sciences, Medanta. After doing his DM in SGPGI, he worked in GB Pant, was a professor, head of department for several years, trained a large number of students and was very active in the fields of both IBD and IBS, and has also uh, published a lot in this area. He's an excellent teacher, and it's a privilege to have him this evening here to talk about certain Indian aspects of irritable bowel syndrome. Amrinder, over to you. Waiting to
Thank you,
listen to you.
Dr. Nagi, for the kind introduction. And I'm kind of overawed because Professor Gui is there, and he's one of certainly the biggest guru of IBS in India. And in fact, my slides are going to overlap with his slides. So if you get the feeling of the deja vu, you know who's responsible, because Professor Gui came earlier. So now, moving on, I'm going to be talking mainly on the challenges faced in India. So uh, as soon as my slides come on, can we have?
Yeah, yeah, I
Okay,
think, yeah, it's
I'm okay. Are my slides there, Dr. Nagi? Can I
yeah,
start? Okay.
yes, you can
So
start.
I'm going to be talking specifically of challenges of managing IBS in India, which I think is quite a task, and given that I have only about 20 minutes to go. And of course, as I said, there is going to be a deja vu that you see. But I'm going to start with what is the normal stool frequency. So if you compare East versus West, you can see from India, from Iran, from China, the average stool frequency is 1 to 2 per day. It's the Europe and US which have much more variable, which goes on 3 per day to 3 per week. So it's almost like a bell curve with two tails. One end of the tail says 3 times per week, and the other end of the tail says 3 times per day. The problem with this is, as you can see, this is the Bible of the IBS. And I want you to concentrate here. Of course, Professor Gui mentioned about the world guru of IBS, Douglas Drossman from Chapel Hill, North Carolina. But if you look at the editors, they're all from the West, and they're all from US except Jan Tak in Belgium and John Kello in Australia. And we don't have any Asian as such because Lin Chang works in California. So what they see is perhaps what is covered in Rome 4 is a totally Western perspective. And I have this cartoon which says that if you want a giraffe to paint the portrait of a beautiful lady, then this is what you're going to get, because that's what he sees. It's not his fault. So this is the problem with Rome 4. The data that they have analyzed is essentially from the West and maybe from Australia. So because of this, there's shortcomings and it doesn't suit us. Coming back to India, there is enough data that IBS is very much prevalent in India. It was thought earlier that IBS is a disease of the West. I think we have ample data, as shown in this slide, which tells us that the prevalence of IBS, whether you look at the rural community or in metro cities, then the prevalence of IBS varies between 4 to 7.5%, no matter which criteria you use. What is interesting to note is that in India, as opposed to the West, which is a female-dominated disease, here it's either equal sex or slightly in favor of males. So this is one major difference that we have from the West. And I know Professor Gui has already talked about Rome 4, which has been there since 2016. And I am just going to read out this definition because I want to stress on one point. It says that as per the Rome 4 criteria, IBS, the diagnostic criteria, recurrent abdominal pain on average for at least 1 day per week in the last 3 months associated with 2 or more of the following criteria. And the 3 criteria are listed here. But as I look at it, this line is completely redundant. So it could just have been recurrent abdominal pain on an average 1 day per week in the last 3 months associated with the change in the frequency of the stool or change in the form. So there was no need to have these 3 criteria, because you can just put it in one running sentence and include both these aspects of change in the frequency of stool and associate with the form of the stool. So that's one point that there is room for modification. as already pointed out by Professor Gui, there are pitfalls. And the pitfalls in the Rome 4 is that, and this is word by word from the Bible, which is the Rome 4 manual that has been published. It says, IBS, presence of abdominal pain is mandatory to make the diagnosis of IBS, and a diagnosis of IBS cannot be made if abdominal pain is absent. It's like saying no woman, no cry, no pain, no IBS. So that certainly doesn't apply to India and I think most parts of South Asia. In this slide, you can see I've put the Rome 3 criteria on the left side, Rome 4 criteria on the right side, and the comparison between two has already been, the differences between the two have already been alluded to by Professor Gui. But on a more philosophical note, I want to know what changes were made in the 10-year period from 2006 to 2016. I think there were really cosmetic changes in 10 years. It's like changing the name of Bombay to Mumbai. So what we've said is that we've reduced from 9 days in Rome 3 in the last 3 months, it has become 12 days. I think they're almost tallying with the rise in inflation, and we've changed improvement with related. But the most important point is that abdominal discomfort has been eliminated and replaced by pain. Now, I'm sure that people working in South Asia and specifically in India would find that very hard to digest. And I think the differences between Rome 3 and Rome 4 are really the differences between Tweedledum and Tweedledee. Because as far as I see, the way I look at it, pain and discomfort are subjective symptoms. A severe discomfort is a pain, whereas a mild pain is a discomfort. So I don't think it was such a big thing to change discomfort to pain and have 10 years to bring about this change. Specifically, I was asked about challenges in India. So what are the challenges that we face in India? The first one is, which diagnostic criteria should I use or should all of us use? And the Achilles heel, as I see it, is subtyping of IBS. I have my subsequent slides would highlight this issue. And I feel very strongly that in India and also in South Asia, the organic disease needs to be excluded. Professor Gui alluded to this point, and that is one plus point of the European criteria, which they use for IBS. They have, the red flag signs are mentioned there. If these features are there, then one should think of an organic disease, which is not there in the Rome 4. And lastly, what is the right therapy? Professor Gui has already dwelt on this, and I think you already know the answer. So there is no standard of care. Each patient has to be tailored accordingly and individualized. And as I was talking about, I said there is a word of caution. So this patient whose CT you can see over here was seen by me, and she had been following up with a junior consultant who happened to be my student. And when I got her CT done, you can see over here it's a significantly dilated downstream dilatation of the ileum. You can see a purse string cecum. You can see a stricture over here, and clear-cut tuberculosis would be the first diagnosis. So I questioned him. I asked him and I rang him up, and he said, "Sir, she fitted all the criteria of Rome 4. She had pain, she had diarrhea, no significant fall in hemoglobin. So was I wrong in treating it?" So that's when it struck me that the Rome 4 criteria, as well as the Asian criteria, must have a subsection where they say there should be a red flag corner, as in the European criteria. So as I see it, the challenges of management of IBD in India are, we're using the Western criteria, and here I'm going to say we're using the American criteria and trying to fit a square peg in a round hole, and then you end up nowhere. Now I'm briefly going to review the Indian IBS data, and as I see, the stumbling block is really the definition. Just to show you, the IBS definition is one has to take a call. Which is more important as a diagnostic criteria, pain or discomfort? Professor Gee has also referred to this. But as I mentioned, abdominal pain in South Asia is present in only 1/3 to 2/3. So we have at least 1/3 of the patients who will not have abdominal pain. So clearly, the Rome 4 is not suitable for India. And now, of course, Professor Gui has already alluded to this. We have the Asian criteria. So I put the Manning criteria here on your left, the Rome 4. And what we have the Asian criteria, which is much better because it says recurrent abdominal pain, bloating, or discomfort, all have been included for 3 months. And they really haven't gone into the mathematics. Rome 4 is really a mathematical approach. You have to calculate for 1 day per week in the last 3 months. This is straightforward. You have these 3 symptoms for 3 months that are either improved or aggravated by the passage of stool of flatus. And these symptoms, actually, this is taken from here, can be associated with change in the stool form or frequency and other symptoms, including urgency, and importantly, the feeling of incomplete evacuation or defecation. So the salient features of this ISG task force study, which was published 2008, was that there is pain or discomfort in the lower abdomen in 70% of the patients, lower abdominal fullness. Now here it was pain, here it is fullness in 70%, but importantly, upper abdominal discomfort in almost half the patients. And they also showed that abdominal pain, discomfort, or lower abdominal fullness was relieved by defecation in majority of the patients. So the inferences from the task force study was that the pain in IBS in India is poorly localized, and it can occur anywhere in the abdomen, upper abdomen, lower abdomen, central abdomen. And I also feel that pain and discomfort in this task force study were used interchangeably by both patient and physician, which was inevitable. But the bottom line was that the defecation relieves the pain in the vast majority of the patients, and more than 3/4 reported a feeling of incomplete evacuation. So I have abbreviated this as FICE for my subsequent slides. This was not I haven't coined this. This is what I learned from Professor Gaur Chaudhary. He used to use this FICE. So the crux of the ISG statement was that since pain is not a dominant feature in India, therefore there is a need to modify the diagnostic criteria. That was the crux of the statement way back in 2008. And they really said what it meant was that we are comparing apples and oranges when we take the Western perspective, given their stool habits and their dietary and fiber intake as compared to the Indian or the South Asian experience. We are all aware of the IBS subtypes. So IBS diarrhea would be when 3/4 of your stools would be in 6 and 7, whereas IBS constipation would be when more than 3/4 of the stools are Bristol type 1 and 2. Now the Koreans have also put forward their statements that Bristol 3 should also be included. But as of now, I think we leave that and take it up in discussion if there are any questions related to this. And lastly, there is the IBS-M, which is mixed, right, that the patients keep on flitting between diarrhea and constipation. So from a patient perspective in India, you will have a patient who will say, Doc, I'm having 6 stools per day, therefore I'm having a diarrhea. And the next patient you're going to see is going to say, Doc, I'm having 6 motions per day, and yet I cannot clear my bowels, therefore I have constipation. Now that is the patient perspective in India. For the same number of stools, one patient is going to say I'm having a diarrhea, whereas the other feels he has constipation. Because 2 parameters are used. One is if you go by the number of stools, then the number of stools being more than 2, that qualifies as a diarrhea. But if the yardstick is an ability to achieve a sense of satisfaction after defecation, and if that is not there, then the patients interpret that as constipation. So this is typically an Indian perspective that I'm putting forward. A feeling of incomplete evacuation can be interpreted as either a diarrhea or a constipation. It's like looking at a glass and saying whether it's half full or half empty. The glass is the same, it's just the interpretation changes. And because of this, we have difficulty in subtyping of IBS. And what does this lead to? We have difficulty in prescribing treatment for the physician. So there is an absolute difference between the East and the West. What is common in India is a feeling of incomplete evacuation, whereas the Western perspective is you have abdominal pain and then dichotomous. Either you have a diarrhea or you have constipation. And this slide, this is what I refer to as the Great Indian Paradox. This is from the ISG Task Force study published in 2008. And if you look carefully, one scale is IBS-D, the other scale is IBS-C, and the median stool frequency was 14 per week, which makes it 2 per day. So exactly the same. So this is what I was alluding to in my earlier slide. It's the patient's perspective, how he looks at it. But what surprised me in this study when I read it was, how would you say that a patient has IBS-D when he has just 2 stools per day? And for that matter, how would you say that the patient has constipation when he has 2 stools per day? So we are really going by what the patient has been saying. And this is what I refer to as the Great Indian Paradox. You are aware of the African enigma, which is most of Africa, about 90% has H. pylori, and yet very little peptic ulcer there. And this is the Great Indian Paradox. So how does one solve the riddle of feeling of incomplete evacuation? Because the patient comes to you with, let us say, 4, 5, or 6 stools per day. So you have to choose now. And what is the interpretation by the general physician? What is the interpretation by the physician or the internist? And finally, what should be the interpretation by the gastroenterologist? In my practice, I found that there is uniformity between the general physician and the internist. But this is where what the role of the gastroenterologist is. If you remember the last couple of slides which Professor Gui showed, that what is the role of the gastroenterologist? It is in interpreting the symptoms and analyzing them correctly. That's the role of the gastroenterologist. So the ISG task force actually suggested that we should go by a patient-related definition rather than a physician-related definition when you're trying to solve the riddle of FICE. Now, I personally completely disagree with this, because if you, as I mentioned earlier, if a patient has 6 stools, he can interpret that as a diarrhea or a constipation. So as far as I'm concerned, the true constipation is I would show the patient the Bristol chart and ask him, what do your stools look like? I'm not going to take what he says. I'm going to show him, look, this is what the Bristol chart is. Now you tell me, what do your stools look like? And then I ask them, is there a need for finger evacuation? If there is a need and he says there are pellets coming out and the stool frequency is less than 1 per day, then these are the true constipation. Whereas the others, I would say that this is the FICE is a part of the IBS diarrhea. I'm also, all the time's running out, I'm also going to touch upon a unique Indian perspective, which is, I'm sure it is there in Singapore and Malaysia as well, that our patients, the IBS patients, come with this feeling of gas, and this gas goes everywhere. And the gas goes into the head, and that's when they become really disturbed. And on a lighter vein, this point was exploited so well by one of my earlier teachers. He would actually take a BP cuff and put it on the patient's forehead and inflate it to about 160 and 180, and then immediately release it. And when the gas, the sounding, the hissing sound that came, and the patients, these females, they actually felt better, and they would come every month or so. So although Professor Gui may not be on the same page as this, but there is a definite psychological component in IBS. These points is also, I mean, we are overlapping of slides with Professor Gui. The question is, who should manage IBS? Should it be the gastroenterologist? Should it be the psychologist or the psychiatrist? Uh, we all know then there is an overlap of symptoms. So approximately anywhere between 40 to 94% of IBS patients will have depression, anxiety, or somatization. Now, I personally feel that most gastroenterologists in a busy practice certainly do not have the skill, the knowledge, and the time to correctly diagnose depression, anxiety, or somatization. So there is a definite role for the psychiatrist to come in these patients. The percentage can vary. Professor Gee feels it is just about 5%. In my practice, it's certainly more than that, maybe even up to 20 to 30%. It's not important to say whether this is a gut-brain interaction or a brain-gut interaction, which came first. The IBS symptoms came first or the psychiatric symptoms came first. If the patient has them at the time of presentation to you, then you have to solve this problem. The other thing that he touched about was the FODMAP diet. Now, although time is running out, FODMAP diet is originally evolved from Australia. In Indian patients, given the diet that we have, specifically in North India, it's very difficult to prescribe a low FODMAP diet. But should you wish to do that, because the compliance is very poor and our knowledge is also not so good when it comes to each and every dietary item, there is a definite role of a dietitian if we wish to manage with the FODMAP diet. So Professor Gui showed about the Rome, all roads leading to Rome. If you're in the West, then as far as the diagnostic criteria for IBS are concerned, then certainly all roads lead to Rome. But as I've tried to argue out my case, that in South Asia, we have a South Asian variant, which is characterized by the absence of pain in almost 1/3 of the patients, with the pain being in the upper abdomen and meal-related symptoms. And of course, FICE, which I've touched on in some detail. This is my last but one style and slide, and this is from from Niels Bohr, where he says that prediction is a very difficult thing, especially when it's about the future. And this is for Professor Gui, because he predicted that the Rome diagnostic criteria are inappropriate way back in 2009. And he suggested in that article that the first step in this journey is to develop our own Asian criteria. So not only was his prediction correct, but we also have the Asian criteria, which I think is a big achievement. And we should, if I have to give a vote, it is clearly in favor of Asian criteria vis-a-vis Rome 4 criteria. Thank you very much for your patient listening, and I'm happy to take the questions.
Thank you, Amarendra. That was a fantastic talk, taking the Indian perspective. In fact, there are many, many practical points you told us. I know that it's been a long day, but we have a very important question answer session. There are many questions coming up, and to help us with this area is we have with us also Dr. Manu Tandon, who is a senior gastroenterologist and director of clinical services at the Asian Institute of Gastroenterology in Hyderabad. A very large experience with this group of patients, so he'll come in here. Now, let me first start by again congratulating both the speakers for the excellent talk, the practical perspectives. We'll ask Manu. Manu, this has been a question that's coming up frequently regarding pain versus IBS. I think Amarendra has very clearly told us that pain may not be a very important factor. And in fact, one of the persons asking us is that if pain is severe, wouldn't it go against IBS, severe pain? Because he showed us this nice CT scan where the patient actually had a stricture and severe pain.
Yeah, but that's after excluding. Otherwise, Nagi, in our day-to-day practice, the first thing that helps us separate pain may not be there in all IBS patients, but the first thing that separates it from functional bowel and IBS is pain. So if there is pain, it is definitely going towards IBS. Pain includes discomfort and disturbance.
Yeah, but
So
that's
severe
the debate
pain,
that Amrinder went into, that should we give
yes,
pain
one
importance
third
at all,
will not
because
have
many
pain.
Indian patients having IBS may not have pain or discomfort.
I didn't get that, Nagi. I
No,
didn't get
no.
the question.
I think Amrinder was telling us that many Indian patients with IBS may actually not have significant pain or discomfort, and can we just brush it off saying it's
Yes.
not IBS?
No,
So,
no, no. You cannot. You cannot only on the basis of absence of pain.
Yeah. The other thing is that people are asking questions regarding threshold for doing colonoscopy. Again, Professor Gui told us that we don't have to investigate these patients. In your opinion, again, very practical opinion we want is, you have a patient coming repeatedly to the IBS. At what level would you think of doing a colonoscopy? Wouldn't it help psychologically for the patient, for you sometimes not to miss a rare diagnosis? We know it's not a very difficult procedure and so on. So this argument goes on. Should
Yes.
we wait? What do you think, Manu?
Young person, long history, other tests negative, 3 4 times. If they have come to us and are still not satisfied, and you have this either incomplete evacuation versus diarrhea, in our setting, it is easier to do a colonoscopy, reassure the patient, reassure ourselves. Amrinder's case is a classical picture. So, not maybe the first time, Nagi, but if that same patient has visited you 3 times, this is without alarm symptoms. If they are alarm symptoms or a strong family history or an age, then it goes priority. I'm talking of a pure IBS. 3 visits, 4 visits, missing work, quality of life poor, not satisfied. I would advise, and probably as our place, we go ahead with a colonoscopy. It's a 20 minutes job. We don't consider it a very advanced, therapeutic procedure or a diagnostic procedure. So
Yeah,
we
I
go
think,
ahead.
yeah, Professor Gui showed that slide of how endoscopy is easier than talking to patients. I think
Yes,
he was
yes.
quite right on
Sometimes,
that.
at least after the third visit, definitely yes.
Yeah. So,
Professor
Professor,
Manu, can I come in on
yeah, please,
this?
Amrit, please.
Just a practical thing. Some patients are reluctant for a colonoscopy. So if you're suspecting a colonic disease, maybe you can just do a fecal calpro.
Yeah.
Because if the fecal calpro is less than 50, you can tell the patient the chances of finding anything substantial on colonoscopy is so so slim that you can easily avoid an invasive procedure.
I think that's an
Maybe Professor
extremely good
Gui
point.
has something to say on that.
Yeah, Mohan, you want to
Would
add?
you combine CRP also, Professor Puri? Would you combine CRP along with fecal cal for positive, negative predictive values?
Yes, I could do that because as long as see both these are totally non-invasive, so it certainly saves the patient the discomfort. And I don't know whether colonoscopy causes a discomfort or a pain. That is still, Professor Gui. In lighter vein, I wanted to say that regarding the Rome 4, because they deleted discomfort. Discomfort is the feeling you got when you were sitting in the bar, and your ex-girlfriend walks in with her new boyfriend. So that's discomfort. I'm sure there is a word in every language which describes this feeling. It's not a pain; it's a discomfort. So colonoscopy also but most people do it under sedation. So
So, thank you. Professor Gui, this is in your talk, you talked about only 9% of the patients wanting dietary advice. This is different in India. Every patient with IBS wants a detailed dietary advice for some reason. So, we come to this other question regarding the famous article in New England Journal on rifaximin showing that how effective it is. So, what is your threshold for doing breath test in these patients? There are some Western physics, for example, like Satish Rao says that almost every patient with IBS should get a breath test done. Do you advocate this, or you're very selective?
I will take it from a more pragmatic, practical approach. So if the patient, I'll tell the patient, you can either do a breath test, which will cost you X amount of money, or you just bite the bullet and start on the rifaximin treatment? Because ultimately, so what's the point of a breath test is to validate that you need the antibiotic treatment. Then I also tell the patient the limitations of the breath test because I think in some centers the pickup rate is 40% of all SIBO patients. What we need to keep in mind is that with irritable bowel syndrome versus a severe small intestinal bacterial overgrowth where you have malabsorption, you have loss of weight, you have vitamin deficiency. In irritable bowel syndrome, the level of SIBO is a very mild, low level of SIBO. So you may not pick up, the test may not be sensitive enough to really pick up the majority of people with IBS and SIBO.
Okay.
So rather than paying the cost of SIBO test and the cost of rifaximin, if they are comfortable with just going full on with antibiotic, particularly a topical one with minimal side effects, I think many of them will choose just to go for the treatment.
So, what percentage of your patients are on rifaximin? How many? Suppose you have 100 patients with IBS. How many of them would you put on any criteria other than diarrhea that you have to put them on
Okay,
rifaximin?
so the limitation for us in Singapore is we only have one source of rifaximin, and it's the original brand, so the cost is extremely high. Whereas if like I understand in India you got multiple brands
Yeah.
and it's cost effective, I think more patients will be comfortable with just going for the antibiotic treatments.
Yeah.
So
Thank
for
you.
me,
So,
I think it's only a small percentage, 10% who will eventually end up with rifaximin treatment.
that is very small. What about you, Amrinder? What percentage of your patients would you put on rifaximin?
IBSD, my percentage would be 25 to 30%, sir. But
Yeah.
the problem is that after 6 weeks, they come back and say that after 6 weeks of stopping treatment, they come back and say we're back to square one.
Yeah.
Yeah.
So
Yeah.
would you do repeated rifaximin therapies like Professor Gee said it's so cheap in India? So would you put them once in say 3 months on rifaximin and then patient is happy?
You could do that, but beyond 2 or 3 cycles, it really doesn't help. After that, they get used to it. This is a peculiar feature. No matter which drug you start them on, initially in the IBS, there's an excellent response, and then after some period of time, there is, if I can say, a tachyphylaxis. The patients don't respond anymore. So
As,
there is a
uh,
limit.
yeah. So as we're staying with you, Amrinder, what about in North India? We know that gluten sensitivity is very common, and you have non-celiac gluten sensitivity there. What percentage of them are actually like IBS coming to you, and do you do anything to exclude this problem before you say that it's not related to gluten?
Well, Nagi, that's a very relevant and pertinent question because where I work now, most of the patients have already gone through the internet and Google, and they've all brought their data to show me. But as a rule, that I would be very careful about excluding true celiac disease in these patients, which means that in almost all patients, before I make a diagnosis of IBS, I would have done a hemogram and I would have done a TTG. So I would have already done that. And if they are negative, then I would say, look, since you've gone through all this and you don't fit into the category of celiac disease, but yes, there is NCGS, non-celiac gluten sensitivity, so we can give it a try. And some patients actually respond to a gluten withdrawal. But here I would also add that as compared to the true celiacs, these patients are not as strict about the gluten-free diet as the true celiacs. So they want to go off wheat or roti, as we say in the North India. They want to go off roti, but they're okay with biscuits or something else, which is definitely not true for celiac disease. We tell them gluten is an absolute no-no. So what these patients probably do is to cut down the gluten in their diet rather than taking it off completely.
Yeah, I think
Nagi,
Manu will agree that the same
here.
experience for us also here. We'll go to Mohan after this. Manu, I think
Yeah.
for us also we find in practice, some of them you just ask,
Yes.
they're not celiacs, but you ask them to be off
Correct.
gluten, they have a dramatic response. Yeah.
They have, yes.
Staying here, Manu, and we'll go to Mohan after this. What about post-infectious IBS? We seem to see that quite a lot. Professor Gee, of course, is one of the world's experts in this. What percentage of your patients are post-infectious, and would you treat them separately?
Is this a question to Manu?
Yeah, Manu and
No,
you, both of you.
Okay. Yeah, that is what I wanted to add. It has, like in North India, you're thinking of celiac disease. In South, in our place, we see a lot of Giardia lamblia. And even giardiasis can produce a fructose malabsorption, can produce a jejunal mucosal epithelial damage, and can lead to
Yeah.
more, even fat malabsorption can happen. So I think we see it in waterborne disease. And when I started my practice 33 years ago, I used to sit with a motion sample and look at a microscope. So it was Professor Madana Gopal and my teacher showed Giardia lamblia, motile Giardia under microscope. So I used to sit and watch. And that is why I found out that a lot of these guys who we brand as IBS probably have still giardiasis because of water pollution. So we just that is one of the important infections apart from the small intestinal bacterial overgrowth. And we aspirate the jejunal fluid and also do biopsies at VGM. We have automatic culture system. Within 5 minutes, it will be seeded into the machine. And we have demonstrated various bacteria. Only problem we have is we cannot demonstrate anaerobes at this point of time. But we have more of gram-negative aerobes and gram-positive aerobes. Once you treat them, they all do well.
Manu, I think there's an audio problem for you. Manu, you able to hear? Or
a
some
little
problem?
low it is coming, Nagi. Your sound is coming a little, the volume is a little low. I can follow, but you have to be straining a little.
Okay. The same post-infectious, in fact, we'll ask you.
Yes.
Yeah.
You
How
know,
common?
what Mohan rightly, the celiac at least is in pockets in India. Some areas very high. We would all know that north and extreme, some places in the south. We see non-celiac uh, wheat allergy if we see, but being a tertiary referral, we should be prepared for some set of people to be celiac. It's the infectious and the post-infectious what Professor Gui has actually worked on, which I feel is one of the most important etiologies for our thing. And it's really, I feel, the duration of the antibiotic given, if it was an incomplete course, let us say, before the infection was got rid of, I feel it is this set which will eventually land up in irritable bowel.
Okay.
It's not
Okay. Yeah.
the type of infection, it is how well we treated in the primary course, and did we eradicate it fully
Yeah.
or we left it halfway. And that halfway one, you saw Professor Guiz goes through all that permeability, bile acid, and all
Yeah.
that comes, mild immune allergic reaction, all come into play, and you land up. So I feel, at
Yeah.
least in our localization, post infectious is important.
Yeah. I think Professor Gee is agreeing with you. Professor Gee, regarding Singapore, I thought there was no infections in Singapore. You're very clean.
So I want to bring in a different perspective. In fact, it's the other way around. That I have this hygiene hypothesis
Yeah.
that if you grow up in a clean environment, your gut immune system is not trained to handle the insults when you get an infection as an adult. And then your immune system goes into overdrive, which then creates all the fallout that leads to IBS, all the sensitization of the enteric nerves, the immune activation, the intestinal permeability. On the other hand, if you grow up with environment full of parasites, as a child, your gut is trained so that when you get assaulted as an adult with an infection, you handle it in a very amicable way.
Yeah. I think I
Professor
agree with you. In
Gui,
fact,
can
yeah.
I interrupt?
Go ahead.
Professor Gui, what should be the incubation period between the end of the infectious episode versus the onset of the IBS? Is there a defined period?
Yeah. Okay, so what we have done traditionally is to apply Rome criteria or the European criteria or the Asian criteria, which is like if the symptoms persist for more than 3 months. But if we go back to the fundamentals, generally we think that infections will clear after 2 months. So in my kind of observation, anyone who has persistent symptoms after 2 months, we should start thinking about irritable bowel syndrome.
So
I think that point is very important because sometimes the patient says, I had a diarrhea 1 year ago. So if he had a diarrhea because of some infection 1 year ago, you would be on a sticky wicket to say that this is post-infectious IBS. And diarrheas are so very common in India. I think all of us have had multiple episodes. So it becomes very difficult to say it's post-infectious IBS.
Yeah,
So
of
which
course, you
of
only
these
reach a diagnosis of IBS when you have done enough tests, particularly with good stool samples, because as someone mentioned earlier on, jardiasis, Dr. Mohan Prasad says, can actually lead to some chronic disturbances in the gut flora, but as well as the some mild villus atrophy that can continue to drive symptoms. So I think good stool studies to exclude certain potentially chronic GI infection is very important, especially in our part of the world.
and Amarendra, I'm very impressed that you have a Bristol chart in your OP. We have been trying to do that, have a Bristol chart in the OP and show our patients which type of stool it is so that they can point out. We've not been able to do that consistently. So you have actual chart
It's not there.
posted.
It's not there. It's on my phone. I just show them on the phone.
Okay, okay.
It's so convenient.
Yeah, I think.
Now it's
So our
on the
plan was
phone.
actually put it in every OPD, so that you just point out and then it becomes
It,
easy.
the phone is good enough, sir.
Yeah. I
You,
think
you can
that's a good
enlarge
idea.
it. And, yeah.
Yeah, that's a good idea. So I think now we come to a very important question that's being asked. This is again to everybody because microbiome seems to be so important in the pathogenesis of IBS. Is there a role for FMT, fecal microbiome transplantation? I think recent report in gastroenterology seems to suggest that you can get an enduring sort of relief in these patients. Starting with Professor Gui.
Okay, in my opinion, FMT is the ultimate probiotic.
Yeah.
Because it completely changes the gut flora. But if you look at the evidence, the studies are divided. There's, I think, there's as many studies on one side that say it works as on the other side that say it doesn't work. And then we also have to be cognizant of the potential risks of FMT. And then for a non-life threatening condition like IBS, my personal opinion is that it's not worth the risk. So in the end, who are the people who are going to be prepared to undergo FMT? And as with every treatment for IBS, the ones who are desperate, the ones who are willing to try everything and in denial of a psychological problem are the very people with psychological problems.
Yeah. You Amrinder and Manu?
I total agreement with Professor Gui. I think this is really. I have no personal experience of FMT in IBS at all. In fact, the IBS, the FMT, which when it came with a big bang, but everywhere it seems to be going down. Even in ulcerative colitis, there are clearly two schools of thought, and the Dutch have clearly shown that it's probably not as effective as it was originally made out to be. Of course, there is a concept of the super donor, which in India is referred to as a wiki donor. I'm sure Professor Key will know that, but we have the concept of wiki donor over here. But even in PSC, in so many diseases, FMT is really on the way out. The only place where it has stood and made a mark is in recurrent C. diff. If you have recurrent C. diff, that is the recognized where there is evidence-based medicine to say that FMT is the therapy of choice. It's the standard of care.
Yeah, Nagi, even I agree. It's the jury is out, because if you think FMT is going to work, then all your other pathogenic mechanisms, and some of them, at least the neurological part, visceral hypersensitivity and all, will be thrown out, because I don't think FMT can influence that part. As Dr. Gui said, it's a complete pre and probiotic. So I think we cannot make a comment. Amrinder showed that slide. Very difficult to predict its role in the future. So, board statement, I think
There are
I
many
would
questions coming in our, yeah, thank you, Manu. There are many questions coming in our chat box. Most of them we have answered, but there's one on prucalopride, whether what is its role in IBS with constipation? Is there a role for it here? Anybody can
you
take
know,
up that?
you
Yeah,
want
Manu.
me to take it up? If you see
Yeah.
it in constipation, chronic constipation is basically chronic constipation, basically three types. The slow transit one, at the most, Ghoshal also had a study, 30 to 40%. The other 40% is normal transit or dyssynergia. So technically, prucalopride should not work in that group. If anything, it has got a role in the slow transit. Some people say it has also got a role in normal transit constipation. So that is where I think in IBS and C, it is worth a try. I'm not sure of studies. Probably Dr. Gui or Amrinder can tell me whether the IBS C, what is the colonic motility like? So that if it is, whether it is slow or normal or there is another mechanism. So
So, Professor G,
limited
I can
role.
share that.
yeah. Do you use it in Singapore, prucalopride?
Yes, I use it a lot and I actually like it. Okay, so what I can share is that Professor Yan Tek actually did an analysis of all the studies with prucalopride. And actually he found that the strongest effect of prucalopride is not on the constipation symptom, but it's on the bloating. So if we
Yes.
take it that bloating is such an important part of our Asian IBS symptoms, then I see a big role for prucalopride. The issue is that it can also potentially cause diarrhea. So obviously you want to avoid it in patients with obvious diarrhea. But what about the patients with mixed or the patients with mildly constipated IBS? Then what I've tended to do is to play it safe. Instead of using the full dose of 2 milligrams, I use it 1 milligram. So in fact, with the prucalopride, sometimes we see also an enhancement of gastric emptying. And there are studies to show that prucalopride can improve gastric emptying. So I see a potential role for using prucalopride in patients who have FD and IBS overlap.
Yeah. Thank you. Mebaverin and IBS, Amrinder, I think we use it a lot in India, Mebaverin.
Yes, I think this is one of the most commonly prescribed drugs. Mebaverin is used extensively, and it comes down ultimately.
You use it any specific patient, or would you be sort of generalized in using this in your
No,
patient?
in generalized, I would use it, sir. But the problem that I have with Mebaverin is that after 4 weeks, they come back and say we're back to square one. So
Okay.
it's not a long lasting. The recurrence comes back within 4 weeks of stopping the drug. Within sometimes as early as 2 weeks of stopping the. Even on the drug, they complain that now it's not as effective as it used to be. So clearly, it's a very stopgap arrangement. And I think a part of it is the placebo effect. You give them any new drug, and they have a response which lasts for anywhere between 2 to 4 weeks, and then they come back that this drug doesn't work. I'm sure that is the experience with the others as well.
Yeah.
So it's not a long-term solution to any kind of IBS.
So I think we are having, yeah, Manu, go ahead.
No, coming on mebaverin, where I found it a little, when the patient has got diarrhea and pain and diarrhea, let's put it that way, I prefer dicyclomine because it will have a little constipating effect also. Whereas a person with lower abdominal pain and constipation or whatever we call it, incomplete evacuation in our sense, I feel mebaverin there works better because it has not much role in reducing further, or worsening the constipation. So
Yeah,
that
but
is just a observation.
how long does it? How long does it? IBS is
6 weeks,
practically.
Amrinder, 6 weeks, not more than that.
So I think we're getting answered most of the questions. There are more coming in, but I think the problem is time. You'll all agree with me that this fantastic symposium was worth even a Sunday evening working on it. With all the cricket matches, Professor Gui, we are presently having a very interesting cricket match this evening. In spite of this, although cricket is religion in India, you see a lot of people are watching this program, especially because you're on it. So I think it's big privilege to have you, Amrinder
Thank
and
you.
Manu, in this. And of course, we can go on and on. IBS is like the whole night we can discuss, but I think we're already shooting the time. I'd like to thank Mohan and the VGM Foundation for giving us this opportunity to discuss this very important practical problem that creeps up in practice. Thank you, Mohan, and thank you for giving us this opportunity.
Nagi, thank you so much for moderating this program. And to Professor Gui, a special thanks because it's already 11 o'clock in the night at Singapore, and he's keeping his midnight oil burning right now.
I'm going to keep my eyes open.
Professor Gui, for also you. I mean, we wanted to listen from the horse's mouth because you're a part of IBS. Rome Foundation. So we wanted to listen to you and thank you for enlightening us with a wonderful speech. And to Professor Amrinder Puri, as usual, such a lucid, lovely, crisp presentation, unbeatable. It's an unbeatable innings from you, Puri Saab. So thank you so much. And to Manu Tandon, he's a man with walking wisdom. Any subject you give, he's ready to speak on it. And to Professor Nageshwar Reddy, in spite of all your busy schedule, you've taken almost 2 hours off and have been with us. Very, very grateful to you. I'm grateful to Abbott for providing this platform. Thank you so much. And next week, coming week, Sunday, 7 p.m., we have an important session on gut microbiome. So we have Professor Schnabel coming from San Diego to enlighten us on this topic, apart from Professor Vinit Ahuja and Professor Dr. Siriak Abe from Cochin. So thank you so much. So bye-bye till we meet coming week.
Thank you, Dr. Gui. Thank you, Dr.
Thank you. Thank you. Thank you.
Thank you.
Thank you. Bye-bye, sir. Bye. Bye, Puri sir.